What's up, Ninja Nerds? Glad to be back again, doing another case study with you guys. Sorry we weren't able to do that last week. With the COVID video, it was a little bit tough. There was a lot of studying, a lot of prep that went along with that. So apologize for that, guys. But we're here today. We're going to do a case. The primary chief complaint that we're going to have the patient presenting with is dyspnea, shortness of breath. Okay, so let's go ahead and get started. I'm excited. All right. So first things first, medical disclaimer. The cases that are presented here are fictitious. They're not real. They're created by us. You guys already know this whole deal. They're for educational purposes only. Okay? All right, so we have the first thing. We have our patient, okay? Let's say that you guys are in the ICU. You're rounding, okay? Maybe you're an intern. Maybe you're the attending, right? Whatever it is. You're rounding through your patients in the ICU. One of the nurses comes and tells you, hey, our patient in so-and-so room, who's a 65-year-old woman, is really hypotensive. They have a significant increased work of breathing, and they're desatting into the 60s. You walk into the room, and you can see that the patient appears to be in respiratory distress, and you're trying to ask them questions, but they are so short of breath that they can barely express their actual complaints. Okay? So start thinking about that right away. Someone said, Margaret Rainey, I'm the nurse. Well, here we go. Let's see what we got. So let's just really quickly, all we know right now is that this person is hypotensive. They're short of breath based on this work of breathing, and they appear hypoxic based upon their O2 sats. So just a quick little past medical history. They have hypertension. They had a history of a right lower extremity DVT that they had been anticoagulated for and had resolved. They had CKD3, diabetes mellitus type 2, and they have a history of cervical spinal stenosis. Okay. So that's kind of what we have so far. Past medical history pertinent for hypertension, old DVT that it was anticoagulated, CKD3, diabetes, and cervical spinal stenosis. They're hypoxic, they're hypotensive, and they are having an increased work of breathing. All right. So here's your vitals. They're tachycardic. Heart rate is 150. Their respiratory rate is 40. Their blood pressure is, oh my gosh, 40 over 20. And the sphincters will be tightening with that kind of blood pressure. Temperature is 99.8, so kind of like a low-grade fever. SpO2 is 62%, and they're only on a nasal cannula right now. So cardiovascular, you listen to their heart. It's a regular rhythm. You hear a normal S1, S2. You think maybe you hear an S4. You don't know. It's tough to pick out. But you do hear this murmur, and it appears to be holosystolic. It's heard at the apex of the heart. Okay, so you got a regular rhythm, tachycardic, holosystolic murmur that's heard at the apex. You look at them just as a general inspection, and you see that they're utilizing their scalene muscles to take in breath. There may even be some nasal flaring. There's some intercostal retractions when they're trying to take in breaths. When you listen to the lungs, you don't hear a lot of wheezing. There's just a little bit of expiratory wheezing there. And then you hear some bibasilar crackles. But again, nothing significant. Abdomen, you just push on it really quick, and it's soft, it's non-tender, and the bowel sounds are normal active. Okay? So a lot of you guys are saying pulmonary embolism. Some people are saying ARDS. Someone said, how is this man alive? Someone says mitral regurgitation, heart failure. I think you guys all have pretty good differential diagnoses there. All right, so, but again, to recap, we have a person who's hypotensive, hypoxic, increased work of breathing, history of hypertension, CKD3, cervical spinal stenosis, diabetes, history of an old DVT that was anticoagulated in the past. You can see that he's obviously tachycardic, he's hypotensive, low-grade fever, hypoxic on examination, appears to be in respiratory distress, has a holosystolic murmur at the apex, and he's got some accessory muscle use, and he's got a little bit of wheezing and bibasilar crackles. All right, cool. So that's what we have so far at this point. So my question for you guys is, let's just kind of risk stratify here. So we see a patient that appears to be in very, very sick. Okay, and you're in the ICU. You want to just know, okay, what tests immediate quick test do I need to kind of help me to run through my differentials? Because a lot of you guys are hitting your differentials out there, and I think they're great. Pulmonary embolism, COPD, pneumonia, heart failure, congestive heart failure, sepsis, cardiac tamponade. Again, I think all of these are great differentials. So I guess the question for you is, like, what kind of test would you want to order to just make sure that you kind of rule out some of the quick things to say, okay, it's not this, it could be this. So that's my question. So some people are saying EKG. I think you can't go wrong with an EKG. So holosystolic murmur means that you hear that. So holosystolic is, anytime you hear holosystolic murmur, somebody actually did say that, you want to think of generally a mitral regurgitation or also like a tricuspid regurgitation, depending upon where you hear it. Since it was at the apex, a holosystolic murmur is you hear the murmur during the entire systolic process. And so that's usually indicative of like a mitral regurgitation if it's heard near the apex. It usually can radiate to the axilla. And again, that's usually what we refer to in that kind of scenario. Some people are saying chest x-ray, peak flow, ABG, bedside echo. Their temperature was 99.6, I believe. So they would 98.8. So it was like a low grade, very low grade fever. Okay, oh, holy frick. Someone wants a pulmonary capillary wedge pressure. All right, you want to put a swan in them. All right. All right. I think you guys picked some pretty good. I think even somebody said a CT. CT of the chest, CT of the abdomen. What do you want? CT of what? If you did want a CT, I guess I'm questioning there is. And some people want a D-dimer. Pulmonary function tests. So D-dimers are kind of helpful. They're helpful in a way, in the sense if you have a very like low test probability, pre-test probability, and someone said CT of the chest. So when I say like a D-dimer, I usually don't do these if I have a high like suspicion, a very strong suspicion that they have a PE. A D-dimer isn't going to be very helpful. It's going to be helpful if I have a very like low pre-test probability that I think it's a PE. And so I probably wouldn't order a D-dimer. I don't think they're going to be very helpful for me in this kind of scenario. So I would go straight to something like, a CT of the chest if I was worried about a PE. Someone said SARS-CoV-2 corona test. Honestly, I'm not even going to lie anymore. Anytime somebody has like a low-grade fever and they have any kind of complaints of shortness of breath, there is nothing wrong with getting a COVID PCR. I think that is a great idea. We don't know their vaccination status, so I think getting a COVID PCR test as well. Okay? All right, so here's kind of the big things that I would do, okay? Right away, a chest x-ray, okay? Get a chest x-ray. The reason why is you want to rule out pneumonia. Look for any kind of opacities that may be there. Look for cardiomegaly. Look to see if they have a tension pneumothorax of some kind. Look to see if they have a lot of like fluid overload in the setting of potentially like a cardiogenic pulmonary edema. I think those are kind of be some of the big things really quickly that you can quickly rule out. So rule out pneumonia, rule out that they have any cardiomegaly, pulmonary edema, pneumothorax, tracheal deviation, anything like that. Okay? EKG and troponins, I think, is a great one. I think a lot of you guys did say EKG. I want to make sure they're not having an MI. If they had an MI, sometimes you take out a good chunk of that left ventricle and they have an acute MI and they go into cardiogenic shock of some kind, but they have acute MI. If you knock out that actual left ventricle, that ability to pump blood out of the left ventricle and into the aortic and systemic circulation is going to be decreased. And so what can happen is it can backflow. It can backflow into the pulmonary circulation and lead to pulmonary edema. So that's one thing. Also, their sinus tach. It doesn't hurt whenever someone is having, they're having a tachycardia. I kind of gave it away already. They are having a tachycardia at this point in time with 150. So I would like to make sure, okay, what kind of tachycardia is this? Is this a sinus tachycardia? Is this an SVT? Is this an AFib of some kind? So again, I need to make sure that I rule that out. And I want to check troponins because troponins can help me in the scenarios of potentially an NSTEMI, a STEMI, a pulmonary embolism, things like that. Choking. If someone aspirated, I guess, if they had like an aspiration pneumonia, you may see some signs of an early consolidated tissue in the lungs, but It's kind of tough to say if it just acutely happened. Next thing is an ABG. So again, I get a chest x-ray, I get an EKG and troponins, I get an ABG. The reason why I get the ABG is not to look at acid-base balance, it's to look to see if they're truly hypoxic. So I want to see what is their actual partial pressure of oxygen within the arterial blood. So I want to know, again, what is the partial pressure of oxygen in the arterial blood, and that's why I'm going to be getting a ABG. Okay, so someone already asked that, and we're going into that now, is what about the point of care ultrasound? What the heck is that? So point of care ultrasound is you're just doing a bedside echo. It's not a formal one. So I do these a lot in the ICU. I'll take, again, my echo and I'll take my ultrasound probe and I'll throw it over the heart and I'll look to see what's going on with the heart. Do they have any wall motion abnormalities? Do they have any global hypokinesis there? Is the right ventricle bigger than the left ventricle? Do I see any enlargement of the ventricles? Things like that. So I just do a quick bedside assessment to look to see if I see anything that pops up. Is there cardiac tamponade there? So do they have fluid that's kind of accumulating around the pericardial sac? I'll throw it on the lungs. I'll also look to see if I see any kind of curly B lines that could be indicative of pulmonary edema. I'll look for any consolidation. So point of care ultrasound is always very, very good to have as kind of an adjunct to a lot of your other tests that you're throwing on here. So I would definitely do a point of care ultrasound just to look at the heart. I would want to make sure I don't see any wall motion abnormalities, no cardiac tamponade that's causing them to become super hypotensive and tachycardic. Make sure that I rule out any other consolidations that maybe couldn't get picked up on the chest x-ray, and look for any kind of curly B lines that may be present there as well. Okay. The other thing is I would do a CT chest. I think a lot of you guys have already said this. A lot of you guys have a very high suspicion of PE. I don't think that hurts. CT to the chest would be pretty good. So I definitely think like a CT PE protocol, so doing a CT pulmonary type of contrast study. You give contrast and you look at the pulmonary arteries as they fill up with contrast to see if you see any cutoffs or filling defects would be a pretty good idea as well. Okay. So I think that you guys covered, and I think another thing to add on, I didn't even think about adding that in there, but again, someone with a low-grade fever in the ICU, shortness of breath, having some difficulty, some hypoxia, it does not hurt to get a COVID PCR test, okay? Alrighty. So I think that's kind of cover like our basis right now of what we think would kind of be the go-to here. What would ammonia do? I wouldn't really check an ammonia. I don't know why someone would check an ammonia unless you think that they're having like some type of underlying encephalopathy, like a hepatic encephalopathy. I'm not quite sure why you would check an ammonia. You can comment down there if you would as to why you would do that, but I don't know why you would. Alrighty. All right, so we got the basic test. The next question is, what is the immediate treatment that you want? So you walk in the room, you got to command the room, right? You see the patient, you see that they're hypotensive, you see that they're tachycardic, you see that they are hypoxemic and they're having some respiratory distress. You say, let's get a chest x-ray, let's get an ABG, let's get an EKG with troponins, and then let's also get a CT after I do a point of care ultrasound. You get all that stuff done, you order all the tests, but as you're getting ready to send them off to CT, you need to stabilize them. You can't send them to CT until you stabilize them first. So what kind of immediate treatments are you going to employ on this patient to say, okay, let me stabilize their blood pressure, let me stabilize their hypoxia, their work of breathing, anything in that nature that's going to help them the best possible way I can, okay? So some are saying CPAP, oxygen. Yep, so it's always ABCs, right? So it's always ABCs, so airway, breathing, and circulation. So I have to address the airway first. And then after that, I can address the circulation, which is that she's tachycardic and hypotensive. And so some people are saying fluids, some people are saying vasopressors, some are saying both. Okay, I think you guys are hitting a pretty good step there. So here's what I would do. I would start off with a high flow nasal cannula. This is again just as an option. So for hypoxemia, one of the best things to do is something called high flow nasal cannula, like Optiflow or Vapotherm, things like that, because they give you 100% of oxygen. Your FiO2, you can crank that up to 100%. And you also get very high flow rates, which is good for dead space washout, as well as you get a little bit of PEEP. It's not a ton of PEEP, but you get a little bit of PEEP, anywhere from like 4 to 6. It's primarily nasopharyngeal, but you may get a little bit of lower airway PEEP. But it's just very good for hypoxemia, decreasing work of breathing, helping with dead space washout, helping to, again, really oxygenate the individual. So before I go straight to intubating a person, I'll try to see if I can bridge them with some high flow nasal cannula. Okay? You could consider things like BiPAP or CPAP. I would probably, again, BiPAP, CPAP, they're not going to hurt. BiPAP is very good. It's going to give you PEEP. It's also going to give you get your FiO2, so it can also reduce work of breathing as well. I just don't think that this person fits the exact category of getting BiPAP. Okay, I think high flow nasal cannula would do them justice. The other thing is that they were wheezing a little bit. It wasn't significant, but anytime someone is wheezing, I'm going to do Duanebs. So that's so someone said, sorry, I'm not familiar. I apologize. So Duanebs is basically a combination of albuterol, so a SABA, right? So it's basically kind of like it's going to help to be able to act on those beta 2 receptors and the bronchioles and allow for the dilation of the bronchioles. Also, Duanebs is also not just the albuterol, but ipratropium bromide, which is kind of a muscarinic type of molecule antagonist. And so what it'll do is it'll bind on to the muscarinic receptors, and it'll also cause dilation of the bronchioles because it's going to antagonize that parasympathetic effect. And then it's also going to decrease the secretions that come from, whenever there's a lot of inflammation. So it's just going to help a little bit with the wheezing, help to open up those airways a little bit. It's more of just kind of a supportive care. And then a lot of you guys are saying fluids. I would be very careful. The only reason why is that if you can give a fluid challenge, I think like a little liter bolus wouldn't hurt. I'd give them a liter bolus, but the problem is when you give people a lot of fluids who are having potentially, and again, I'm just saying potentially, I have a high suspicion, I think a lot of you guys too, of pulmonary embolism. That's a lot of right heart strain. And so if you have a lot of right heart strain and you give them fluids and you kind of overload them a little bit, it's going to make it a little bit more difficult, and it's actually going to cause that fluid, instead of getting actually into the right ventricle, it might actually just kind of stay within the right ventricle. Because again, if the right ventricle is under a lot of strain, a lot of stress because of pulmonary hypertension from having a PE, that blood might not actually be able to pass. And so it might be wasteful in that situation. So I say you can give a fluid bolus. I do like a liter maybe of normal saline or lactated ringers, but I'd probably, at this point in time, their blood pressure is so darn low, I would probably just go straight to an infusion. Also, I don't know what their chest x-ray looks like just yet. What if they're fluid overloaded? What if they have pulmonary edema? I heard some bibasilar crackles. That doesn't necessarily mean that they have pulmonary edema, but I don't want to kind of hit them with lots of fluids if that's the case. So I'm just going to put them on a vasopressor, because that's going to really help to clamp down on the vessels and bring their blood pressure up. And I'm going to put them on high flow nasal cannula to get that oxygen up, some Duanebs for the wheezing. Okay? Okay, so some of you guys are saying you'd use CPAP even if the patient is unstable. I probably wouldn't do CPAP in this scenario. I would probably try high flow as a bridge. I probably wouldn't even do BiPAP. I would probably bridge this person with high flow nasal cannula, and if I can't get their oxygen back up with that, I would consider intubating them. Okay. So some people are asking about, I would not give fluid. Yeah, and again, I probably wouldn't give fluid. I'd probably go straight to the vasopressors in this kind of scenario. How would the RV be impaired? Again, we don't know. I'm kind of preluding that a lot of you guys said pulmonary embolism. So if somebody has a pulmonary embolism, you have an emboli within the pulmonary artery, let's say. And so now you're trying to be able to push blood from the right ventricle into the pulmonary artery, but you're pushing it through a very narrow pulmonary artery or a completely occluded pulmonary artery. The pressure proximal to that occlusion is going to go up. And so if that's going to go up, it's going to cause some pulmonary hypertension. It's going to put stress on the right ventricle. The right ventricle will have to work harder. It might dilate. And so instead of that, you give them fluid. It comes via their inferior vena cava or superior vena cava, goes into the right ventricle. It might stay there and instead start backing up into their actual backing up into like their abdomen or their lower extremities, things of that nature. It just might not be beneficial. So I would just go straight to an infusion. So nasal cannula, how long would you wait? Again, it's kind of depending. I would just try it. If you throw it on a nasal cannula and their oxygen O2 sats go up to 92% or something of that nature, then you know it's working. But I would kind of base it upon what your ultimate goal is. If you're putting someone on high flow nasal cannula because they're hypoxic, it should bring their oxygen up. And so that's the whole goal, is to bring their oxygen up and reduce their work of breathing. But you have to think long term. If their work of breathing continues to get worse and worse and worse, they're going to tucker out. Their muscles are going to become weak, their diaphragm, their intercostals are going to become weak, and their ability to breathe at the same rate like that, being tachypnic as they were, they won't be able to sustain that for a long period of time. And eventually they may need to be intubated. So again, it's primarily just a bridge. It's a temporizing measure to hopefully, if we address the underlying issue and address what's causing the hypoxemia, they won't even need to be intubated, and maybe they won't even need to be on high flow nasal cannula. Okay. All right, so we get the chest x-ray. This is what it looks like. So if you guys look at this, again, nothing special here. We see here we have the trachea that's moving down. It's pretty much midline here. I don't see anything particular here. There's no rotation with respect to the clavicles. I'm looking at the lungs. They look nicely aerated. They don't look atelectatic. They kind of look a teensy bit hyperinflated, but nothing significant. I also am looking for any consolidation. I don't really see any really patchy white consolidations or opacifications anywhere within the lungs. So that's important. I also am going to be looking for any kind of pulmonary edema. I don't really notice any pulmonary edema here. It's not really like that whiteout appearance that you would generally see. I'm going to look at my diaphragms. The right usually should be a little bit higher than the left. Look at my costophrenic angles. They're nice and clean. So, and then the heart, usually you would say that it's about, if you were to, I'd say that this is a normal chest x-ray, nothing particularly concerning on their chest x-ray for pneumonia, cardiomegaly, no pneumothorax. I don't see any kind of like distinct loss of vascular markings or pulmonary markings as they go towards the edges here at the apex or near the pleura. So with that being said, I think it's a normal chest x-ray. All right, so we've ruled out pneumonia. We've ruled out a pneumothorax. I don't really see any cardiomegaly, so that's good. All right, let's go to the next thing, the EKG. So if I'm looking at my EKG, how do we read EKG, guys? So first things first, we start by looking to see what's the rate. Well, we already knew that the rate was like 150. So we throw on a 12-lead EKG, and we can kind of test this by looking. Find like where kind of one of the R waves lands on a line here, and then mark it up to the next one. So that's about 2 boxes. Remember, one box is about what? One box is about 300 beats per minute, so 2 boxes is about 150. So we're going to have about 150 beats per minute here. Okay, cool. Next thing is it sinus? So look at lead 2. Do you see a P wave? I do. I see a P wave right here. Again, I see a distinct P wave right there. The T wave is right before that, so you're kind of seeing them build on top of one another, but there's definitely a P wave. Go to AVR. Do I see an inverted P wave? I do. There's my inverted P wave right there. So it's upright in lead 2, inverted in AVR. So I know it's sinus rhythm, and I know that for every P, there is definitely a QRS complex. So it looks like this is sinus rhythm. It's tachycardic, so there's a sinus tachycardia. And then I go down and I do my same thing. After I've done that, I look to see, is there any wide QRSs? No. So it's a narrow, it's regular tachycardia, and it's a sinus rhythm. It's probably a sinus tachycardia. And then you can go through and you look for ST segment deviation. Do I see any ST segment depression or elevation in any of my leads? I don't really see any ST segment depression or elevation in any of the leads. So with that being said, I can kind of tell you right now that this is a sinus tachycardia. Okay. Now, what else do we know about this? Well, the troponin came back at 4.2. That's a little elevated. That's not great. It's not terrible, but it's not great. So it's a little elevated to have a troponin of 4.2. What does that mean? Well, that means that there could be some strain on the heart. I don't have anything that's telling me I have an NSTEMI, a STEMI. I don't see any T-wave inversions. I don't see any hyperacute T-waves, anything that's really scaring me. So I've kind of ruled out an MI. So this is definitely sinus tach, but I got a troponinemia. Why do I have a troponinemia? Is this a demand ischemia? Do I have some issues where that right heart is strained for some reason? I don't know. There's something going on here. So there is a troponin. I don't have an exact idea of why there is. So Peter Fish says, isn't there ST depression? Again, I don't appreciate any ST depression in here. If you can point out which leads you say that you see the ST depression, we can definitely analyze that. But I don't see any elevation or depression in the ST segments. Okay. Alrighty. So let's move on to the next thing here. So we've gotten our EKG, we got our troponins, we got a sinus tach with a troponemia. I do a bedside echo. When I do the bedside echo, this is what I see. So right away, so someone said, yeah, maybe lead 2. Let's take a look at lead 2. Okay, so if we come here to lead 2, so we have here's our going to be, you have your R wave, then you have coming down here into the S wave. So you have to find your J point. If I could zoom in on this pretty well, it's tough to say where my J point is without really zooming in on this. But here's another thing to also take into consideration. I'd say my J point's probably right there. Here's one thing to take into consideration. It is normal to have ST depression and sinus tachycardia. That's completely normal. So that's important to remember. You can have a ST segment depression that is completely normal in individuals with ST segment depression. So ST segment depression and sinus tachycardia is normal. Okay? And also, if I had ST depression in one lead, that's not enough. You usually need it in a couple more contiguous leads also, as well as, again, looking to see if there's any other signs. So again, I'm not completely convinced with that being a true ST segment depression. I don't see it in 2 contiguous leads. And again, it is normal to have ST segment depression with a sinus tachycardia. Alrighty. Hopefully, I hope that answered the question for that. Alrighty. So here's our echo. We look here and we can see something very interesting. So here is their, yeah, no problem, Peter. Yeah, I hope that answered the question. Again, it is pretty normal to have ST segment depression with a sinus tachycardia. And again, usually you need it to be, if there is any ST depression, you'd want it to be in kind of at least 2 contiguous leads there. But yeah, great. All right, so here we have a look here. Here's our interventricular septum. Okay, here's the interventricular septum. This up here would be like your left atria. This would be your right atrium. This is your right ventricle, and this is your left ventricle. Okay, and then you have the pericardial, pericardium right here. So with that being said, do we always read? Okay, so some of you guys are still in the EKG. Lead 3, some low QRS voltage. Again, you check low QRS voltage by, again, you can add up lead 1, 2, 3. Or you can add up V1, V2, V3, and then based upon that, determining if it's less than 15 millimeters or less than 30 millimeters can tell if there's any low QRS voltage. Also, if you're concerned about low QRS voltage, you're thinking that there's probably a cardiac tamponade. We have here our EKG, our echo. So we've already kind of ruled out that there is no cardiac tamponade. But again, it's great thought there. So again, if I'm looking here, I have my right ventricle, and I can see here with my right ventricle and my left ventricle. What do you guys already notice? Now, generally, which ventricle should be bigger? Should the left ventricle be bigger, or should the right ventricle be bigger? The left ventricle should be bigger, right? If the right ventricle is bigger than the left ventricle, then what should you be thinking about? There is a lot of strain that is going on with that right ventricle. That's not good. If there's a lot of strain on that right ventricle, why is that happening? That means that something is causing the right ventricle to have to dilate or work harder to be able to push more blood out. So again, with that being said here, definitely a little concerned here as to why that right ventricle is so darn dilated. Okay, so there's definitely some dilation, some enlargement of the right ventricle. Now, the other question is sometimes people, if you're really good at bedside echo, sometimes you can do something called a TAPSE. So it looks at the tricuspid annular plane excursion, and that can help you to determine if there is any signs of a PE. That can be helpful. In this scenario, I think this is justified enough to say, oh, wow, That's a big right ventricle. It's dilated in the setting of hypoxemia, hypotension, increased work of breathing, sinus tachycardia, a normal chest x-ray, an EKG showing a potentially sinus tachycardia, troponin showing a troponinemia. I got to be a little bit concerned here for a pulmonary embolism, right? And you can check the axis on the EKG. Axis is not something that I kind of like look at too often. There's nothing wrong with checking the axis. I think that whenever you waste time looking at axis isn't going to tell you a ton. It may be helpful, but I don't think that an axis is going to tell you about a PE or tell you about much else. It's kind of an adjunctive thing. You can definitely check an axis. I'm not saying you can't do that, but it's probably at the lower end of what's significant at this point in time right now. So I would say sinus tachycardia, they got a troponinemia, their chest x-ray is normal, their right ventricle is dilated. What the heck is going on here? I'm thinking PE, right? A lot of you guys said that right from the beginning. So what would be the study then to be able to do that? You need to get a CT angiogram. Well, the ABG results came back in the meantime. While we've been putting this person on high-flow nasal cannula, we've been giving them pressors. And by the way, their pressure is going back up. Their pressure went up to where they had a blood pressure of 90/40. So that definitely has improved. Their actual oxygen, O2 sats, did improve before we actually got the... so O2 sats improved, and then we got the ABG before that. So when we do that, the ABG shows a pH of 7.54. We have a PaO2 of about 40 millimeters of mercury. We have a PaCO2 of about 26 millimeters of mercury, and we have a bicarb of about 20 milliequivalents per liter. Okay? So when we read ABGs, you guys already noticed this, that what do? We look to see, okay, this is going up. So if the pH is going up, that's going to be some kind of alkalosis. Well, we got to remember that if that's the case, what would the CO2 do? Well, if that is going up, then we would want the CO2 to go down. They're tachypnic, right? They're breathing really fast. The respiratory rate was in the 40s. So they're going to be blowing off their CO2. So there's definitely a respiratory alkalosis here with having a high pH and a low PaCO2, right? Remember that mnemonic Rome, right? So it helps you to remember that, with that respiratory is opposite, metabolic is kind of the same. So in this situation, this is going up and the PaCO2 is going down. So there's a respiratory alkalosis. The other thing is I look at the PaO2. Oh my gosh. It's hypoxia like no other. So generally you want the PaO2 to be about like 80 to 100 millimeters of mercury. So having a PaO2 of about 40, they're definitely hypoxic. And so putting them on that high flow nasal cannula is going to help. The other question is, are they compensating? They may be beginning to compensate. Generally, normal bicarb is 22 to 26. So generally, if they're alkalotic, you're going to want to try to make them a little bit acidotic, getting rid of some of the actual bicarb. Maybe the way that you do that. So they're starting to drop a little bit of their bicarb, but it's nowhere near compensated enough. Okay, so we got a respiratory alkalosis, which makes sense, and we have hypoxia. Okay. So we get that CTPA study. I think you guys have all pretty much assumed at this point in time, there's definitely got to be potentially, there's got to be potentially some type of PE going on. Okay, so we get the PA study here, CTPA. All right, so it's going to be the CT where you get the pulmonary contrast. And what do I see here? So remember, this is the right side of the patient. This is the left side of the patient. You're looking at it from their feet down. I see contrast here, and oh my gosh, what is this thing right there? And then, oh my gosh, what is this thing right there? We got some emboli here. We got some clots that are clogging up that right pulmonary artery and then are clogging up that left pulmonary artery, right? Let's go ahead and take a look at what that actually looks like. So here's our CT scan. Okay, and we're going to go through this. So we're going to work our way up. So here we have the heart. Okay. And here you're going to have your aorta. Okay. Here would be, this is going to be in this situation here, you're going to start seeing the pulmonary artery here. So we're coming from that right ventricle here and going to the pulmonary arteries. So here you're going to see that right pulmonary artery, there's a big clot there. If we continue to follow this off to that left pulmonary artery, you're going to see a clot there in that left pulmonary artery as well. Okay. So this person is really jacked up. They got a bilateral pulmonary embolism. That's a pretty significant clot there. Okay. So that is our study. So right now we have a bilateral pulmonary embolism. Is it a saddle? So no, saddle would kind of be like, if, for example, if I were to go back on this, a saddle embolus would be like, you see where you have kind of this bifurcation from the pulmonary trunk going into the pulmonary arteries. A saddle embolus would literally kind of like saddle, a kind of straddle, if you will, between these two pulmonary arteries at the level of the bifurcation. So it would kind of like obstruct a little bit right here. Okay, so that would be your saddle embolus. So yeah, this person has a bilateral pulmonary embolism. They all jacked up. Okay? So what's your diagnosis? At this point in time, what is your diagnosis? Which one would you guys pick? Okay, if you had to, like, you know, again, this is kind of like your exam question kind of stuff. Is this a massive bilateral pulmonary embolism? Is this a submassive bilateral pulmonary embolism? Or is this a non-massive bilateral pulmonary embolism? What do you guys think? So yeah, a lot of you guys are, that's unfortunate. Yeah, it's pretty big embolus there, right? Bilateral P, I guess submassive, massive. So a lot of people are saying A, submassive. Some people are saying submassive. Some are saying, okay. Yeah, so I think a lot of people are between submassive and massive. And really the way that you kind of define this is their hemodynamics, right? So if a person is hemodynamically unstable, which this person is, they're hypotensive. We have them on a norepinephrine infusion. They're also severely hypoxic. We have them on high flow nasal cannula. They have troponelemia. They have right ventricular dysfunction. They have a big bilateral pulmonary embolus. So yeah, I'd say that this fits the category of a massive bilateral pulmonary embolism. So it's pretty significant. Alrighty. Does the clinical presentation matter when deciding submassive or submassive? So it's more the treatment that kind of, it really is a little bit of the deciding factor when it comes to massive versus submassive. It's really like, for, you know, in this kind of scenario, it's more the treatment regimen. If you have a person who is hypotensive, right ventricular dysfunction, they're severely hypoxemic, they have pulmonary emboli, they have sinus tachycardia, they're hemodynamically unstable in some way, that fits the category of a massive PE. And there's a little bit of a different type of treatment regimen. You're a little bit more aggressive in that sense. Jan Wolf said, still plenty of space for more emboli. Okay. I guess. Jeez. So submassive can also be hemodynamically unstable, but it's not as significant. Usually with those, they don't have as much of the significance of that hypotension. They may have some RV dysfunction, but they're not as significantly hypotensive and hemodynamically unstable. All right, so massive bilateral pulmonary embolism. So what's the definitive treatment here? In this scenario, you have a person who is having a massive pulmonary embolism, bilateral. What do you treat them with? Do you get them an embolectomy? Do you do TPA? Do you do heparin? Or do you do warfarin? What would you do in this scenario? Okay, so what do you guys think? In this scenario, what would you do? Would you go in there and retrieve that clot and break up the clot? Would you go in there and just do TPA? Or would you do TPA that's maybe a little bit more catheter directed? What'd you guys do in this situation? So, embolectomy. Some people are saying TPA. All right. All right, so you're getting a mixture of TPA, embolectomy, kind of as a little bit. A couple people said heparin. Why not D, B, and D? Okay. Trying to kill somebody, man. Give him an intracranial hemorrhage with all that freaking anticoagulants and fibrinolytics. Jeez. All right, so what I would do here is it's really, I think someone actually answered it pretty nicely. It's kind of dependent upon a couple different scenarios. So first thing is, if I do TPA, what's the risk? So anytime you do a treatment, you have to be analyzing what is the downside, what's the risk of me giving this drug. I want to help my patient, but I don't also want to make their situation worse. So if I give them TPA, what would be a problem with that? Well, they're at risk of bleeding. So if I give them TPA, I need to make sure that their bleeding risk is relatively low. So if they have a high bleeding risk for some reason, I'm not going to give them TPA. For example, let's say that a person had an ICH, or they had recently had a stroke, something of that nature, and I put them on TPA to help with that pulmonary embolism, but they have a very, very high risk of bleeding. Not a chance in this world I'm going to give them TPA. I do the embolectomy instead. But if a person has a relatively low risk, I'm going to push 50 milligrams IV alteplase right then and there if they have a very low risk. So generally, in the kind of acute scenario, TPA is going to be the quick thing that you would do. Okay, so you would do 50 milligrams IV alteplase and you'd push that if their bleeding risk is relatively low. Now, if they have a little bit of a higher bleeding risk, you can actually go in and do what's called a catheter-directed TPA. Spray some of the TPA into that area where the actual emboli is and break up the clot. And then usually if they're very high risk of bleeding or they have failed the actual TPA, then you can do the embolectomy, okay? Heparin in this scenario is not going to be the best bet. So I wouldn't go straight to heparin in that kind of scenario. That would be more if they had kind of like a farther downstream pulmonary embolism. But having the significant pulmonary embolism and being hemodynamically unstable, I probably wouldn't go with a heparin drip. I'd probably go straight with either TPA, and if they failed the TPA, then maybe go to the embolectomy. But again, it's kind of based upon their bleeding risk and about the scenario, okay? So I would say TPA would be the best scenario here since they don't really have a high bleeding risk. And then again, I would push that and then again, see if they improve. If they don't, they failed the TPA, then an embolectomy may be an option as an alternative. Okay? I hope this helped, guys. I hope this made sense. I hope it was an interesting type of case study. So someone actually said shock. Yeah, this is a type of shock. I guess that's a good question for you guys is what kind of shock is this? If someone is having a massive pulmonary embolism, what is the type of shock you classify this as? I guess is a good question. So it's an obstructive shock, right? So yeah, obstructive shock. So some people are saying, but what about the embolus? Again, the TPA is going to help with the embolus. The TPA will actually help to break down the clot there. Again, embolectomy is, there's nothing wrong with doing an embolectomy if you think that they're a high bleeding risk or if they fail the TPA. But TPA is a good quick drug that you can give right away, analyze how effective it is, and you can actually go in afterwards and do an embolectomy. Warfarin is strong, yeah, but again, heparin and warfarin are not going to be drugs that are going to be acting as like fibrinolytics. They're not going to actually bust a clot, if you will. I don't like using that term, bust a clot, but they're not going to really break down the clot. They're going to prevent further clots from actually forming. So again, that's why heparin and warfarin are not really going to be the best in that scenario. Yeah. Yeah, warfarin can be a little bit prothrombogenic and can lead to that warfarin-induced skin necrosis, so sometimes you bridge them with heparin. Well, engineers, I hope this one made sense. I know it was a little bit a lot of questions, and I'm glad we got to talk about it a lot and learn a lot. It's always great to be able to communicate with you guys, and I always enjoy it. You guys keep me on my toes and keep me sharp, so I appreciate it, and I just enjoy talking with you guys so much. It's really fun. I hope you guys learned a lot. I hope you guys enjoyed this case study. I really hope it helped. And hopefully next week we'll be back at it. We'll do another case, and just keep learning together. This is always some pretty cool stuff, and I just hope that this helped, guys.